Hello and welcome to continue. Okay, sorry. Hello and welcome to the Mental Health, White Bias, and COVID-19 webinar hosted by Obesity Canada's Students and New Professionals Executive Team. My name is Kashmol and I attend the University of Alberta and I serve as the Recruitment Director with SNP. Thank you so much for joining us today, and thank you to our panelists who have taken time out of their busy schedules to join us for this educational session. We are so grateful for having you all here and really appreciate all of the work you do in this area. So our aim for this event is really to just bring our chapters, students, and professionals together in a space to discuss anything from the research side to the clinical impacts of COVID-19 on obesity. So I would like to thank our national executive members, Joyla and Malcolm, who serve as the OC-SNP chapter reps, who along with our chapter chairs from various universities, Hannah, Ben, and Wally, were able to come together in helping lead the organization of this really exciting event. So now I'd like to welcome each of our panelists to introduce themselves, and after this we will have the moderators introduce themselves, and then we'll get this event on the road. So we will get started with Julie, please.
Hello, my name is Julie. I'm coming to you from Quinte West, Ontario. I am a counselor who works in the world of body image, eating disorders, disordered eating, and I'm really excited to be here today to talk about how to destigmatize research in this area. I think it's really important from a client perspective, so I look forward to offering that today. Thank you.
Awesome, thank you. Now we have
Hey everybody, my name is Michael. I'm a health psychologist. I'm from Halifax. I'm at Dalhousie University. I've been involved in the field for quite a long time. I was one of the founding members of Obesity Canada. I was on the executive of the first Canadian clinical practice guidelines, and I also have the privilege to be on the executive for the 2020 guidelines, which, stay tuned, August 4th will be released with the publication in CMAJ of the executive summary. And all 19 chapters will be immediately available online for download. So this is, I hope, going to be a really useful opportunity. Really looking forward to this session because I've been involved in a lot of webinars recently, and they're fairly driven by I'm looking forward to, we're hoping it's going by the participants.
When I was on an exam, we had golf ball size hail during the exam, so I'm hoping that doesn't happen this morning. I'm a registered psychologist in Alberta, counseling psychology, and I'm in the Workland School of Education in the counseling psychology department here. And I've spent my career, and even some time prior to my career, working in the area of disordered eating, eating disorders, obesity, and weight bias. I was able to contribute to 2 chapters in the upcoming guidelines, and I'm very pleased to say that there is a chapter on weight bias in the guidelines, which a number of people from Obesity Canada had a hand in creating, and I think that's pretty exciting on an international stage that there would actually be a chapter dedicated to that topic in the clinical guidelines. So I'm really looking forward to the discussion today.
perfect. Thank you so much. And we were also supposed to have Ian today, but unfortunately he's away at the cottage, and so his internet connection wouldn't allow him to join today, unfortunately. But I'm still very much looking forward to the discussion that we'll have today. And just moving on. Perfect. So just a couple of reminders for the event. This is meant to be a very organic, informative discussion. So please listen, ask, and engage with the panelists throughout the discussion. You can ask questions out loud using your microphone or by typing them into the Q&A chat at any time. So the session will be about an hour and a half, and our moderators will be sticking around afterwards to engage in questions and conversation with attendees, so please feel free to stick around a little longer if you choose to. So now I'd like to welcome our our moderators, who will each introduce themselves. We have Ben and Hannah, who will be leading our discussion, as well as Wally, who will be helping us monitor the chat discussions. So we can start off with either you. We'll start off with Hannah.
Hi everyone, my name's Hannah. There's not much to say about me except that I am one of the co-presidents of the Obesity Canada SNP at Ontario Tech University, and I'm just a second-year master's student right now. That's just studying mobile health apps, nutrition, and teaching children about nutrition. So that's just kind of a little bit about my background.
You're not allowed to say just.
I know. I knew as soon as I said that, I knew it would be bad. I knew it'd be bad. Yeah, but that's a little bit about me.
Okay, and then I guess I'll just introduce myself. So my name is Ben, and I'm pursuing a Bachelor of Sciences in Health Sciences at Simon Fraser University. I'm also the chair at the Simon Fraser University chapter for Obesity Canada students and new professionals. I've been involved with Obesity Canada for more than 3 years now. I have presented 2 of the conferences, and I also work as a physician assistant part-time at the medical weight management program. So I do have experience working with patients with obesity. And I also just started new research with the Vancouver General Hospital Trauma Services. We are working on developing a culture of research and developing their research culture. Yeah, so just like Hannah, that's just about me. Although I'm not allowed to say that.
Okay, thank you, Ben. So I guess I'll do me. I'm Wally. I'm the chair of Obesity Canada SNP at York University. I'm also pursuing my Bachelor of Science in Biology at York as well. And I've been involved pretty much with Obesity Canada more as a general member, kind of attending events around the GTA. And so that pushed me to actually take more of a leadership role in Canada, and so I recently became the chair at York. And I'll also be moderating the chat, and I'm going to put some stuff in there if you have any questions. So feel free to ask anything throughout the webinar.
Okay, so I guess then we can just get going with the discussion. We did prepare some topics in advance, so we're just going to go ahead with those. And you can always ask your questions throughout the chat, or if you have any questions, you can always also unmute yourself and speak about it. So because today's webinar is about weight bias, I think it would be appropriate to just start with the topic of weight bias. So a couple of things I wanted to ask and get our panelists' opinion on it is, given this whole public health crisis that we are, living through it, do you think that had, some influence on, on the weight bias and affecting the lives of patients with obesity? And if you, once you want to answer that question, if you could also define weight bias, because I know that some of the people who are joining us tonight may not have been in the field of obesity too long, may not be aware of what weight bias means. So if you could, speak about whether this whole pandemic has caused the worsening of the weight bias for some patients with obesity. Perhaps Julie would be either Julie or Shelly. I mean, you guys are all experts, so.
Yeah, no, I'd love to go. Well, weight bias, for those who don't know, is a negative attitude towards people because of their weight. So negative attitude, negative beliefs, stereotypes, prejudice. I don't want to get kicked off here, but I think just using the word obesity is one of the biggest ways that we continue to perpetuate stigma and weight bias, using a medicalized term. So I don't personally use it. So if I digress from that throughout the presentation, that's just my personal position. So I think COVID-19 and what we've been going through, I'm in Ontario, and what I've noticed from clients is that there's a lot of talk about the COVID-15, and there's this driving force behind this stigma there of, if you're not working towards being better by the time this is over, people are really feeling that pressure to be a better person, a better physique when they leave COVID. First of all, I don't know if we're ever going to leave COVID, if that is actually a thing. But the messages that are coming are overly simplistic. They lack practical solutions. They're stigmatizing, and I think it's perpetuating weight stigma in a way that has a really large impact on people who are living in any type of marginalized body. People with disabilities is included, for sure.
Yeah, Julie, I agree. So just want to add a few things to all the things I agree with what you say. I just think, you know, I think what it demonstrates is that our society is just really obsessed with weight. And so in the face of a global pandemic, when there's people dying by themselves without their loved ones close to them, when people are, you know, isolated by themselves for weeks on end, the thing that we're going to talk about and meme about and social media about is about how, if in lockdown you let yourself go and gain a few pounds, that somehow reflects poorly on your value as a human being. So I just think it's sadly, it's not surprising to me, but it's horrifying to me that would be what people are focusing on in the face of a global pandemic. I think there are other lessons that are way more important lessons. So, and I agree. I think that the focus on the COVID-15 or the COVID-19 or whatever the meme is saying is actually negatively affecting all bodies, particularly bodies with multiple marginalizations. I agree. But I think that becomes a social justice issue, in my opinion.
Yeah, I would just throw a couple of comments to round out what we've talked about. I think for sure that the risk of bias has just increased in this, and we see this time and again. And the fact that there are, you know, sort of the medical risks that are associated with adiposity if you do contract the COVID virus, just actually makes it all the worse. And so, you know, I think it's for me, I see the challenge is that this pandemic is a stress that's actually impacted the world. Tell me, you know, who hasn't been affected by this, and what are the things that we spend most of our time doing? We spend most of our time kind of working. We spend our time sort of socializing, and those activities are completely changed. So we don't work in the same way that we did before. We do not socialize in the same way we do before. So for me as a psychologist, we know that this is a pandemic of stress, and the perception of risk leads to the feeling of anxiety. The perception of loss leads to the feeling of sadness. This is basic psychology 101. And I really get irritated when I hear that idea that, you know, you're supposed to build a whole extension on your house, write a novel, get a Nobel Prize, you know, do all these wonderful things during all this extra time you have. When the reality is we're actually really in survival mode. And you know, so the bias, I think, is a particular challenge because I think we have to understand the role that food plays in human existence. And I think we just have to respect that we love food, end of story. Food and emotions are actually processed in the same part of the brain. And so imagine any celebration that doesn't include food. Have a party at Christmas, don't have any food. People will be offended and they will never come back. They'll leave the party saying, why doesn't he or she like me? So, I mean, I think we have to really, you know, get it away from the food. I just actually saw a paper today in the International Journal of Obesity, and it was a very well done epidemiological study looking at Sweden and access to food and access to exercise, basically demonstrating in a very large epidemiological study there was no relationship between obesity and access to healthier versus less healthy food, and no relationship between obesity and access to physical activity or not. So the narrative of eat less, move more, it really, really has to be disbanded. So those are my comments around the bias issue, which I think is a big risk, and it's really the memes are actually really, really offensive.
That's
Thank you.
yeah. Thank you so much. Yeah, those are great comments. I kind of wanted to jump a question and kind of go back to the quarantine 15 that you mentioned, Julie. I was very curious in a couple more, you know, because that's, I guess, floating around social media a bit more. And I just recently heard of it. And when I first heard of it, I thought of freshman 15, of course. So I know that was I know that was a little bit just discussed, but I was maybe hoping if there was any other comments based on the quarantine 15. So it is considered, I guess, a weight bias in your opinion?
I think for sure you have to look at what Shelly said too about that fear of gaining weight being more relevant than the 98 other things that we should be worried about or considering. The last thing we need to be thinking about is, am I gaining weight? And so I think one of the things that's happening is people for many months, at least in Ontario, and again, I'm not sure about around the world, have lost access to things like chiropractic, physio, massage, ways that they normally alternatively take care of themselves. For me, I was very lucky. Most of my clients did transfer to teletherapy, which has been brilliant, but many haven't because it's not safe for them to do so. So now they're lacking counseling. They're seeing their doctor on a video, not in person. So there's this lack of human connection in alternative therapies, which I think is so important. And then again, we're seeing this constant social media stream of do better, be better, bake sourdough bread, but don't eat it. I'm not really sure how that goes, but it's really been how I would describe our capacity is full. We have a capacity bucket. COVID-19 is filling it up. And then things like weight bias with those memes and that I've never heard quarantine 15, but yeah, that does make sense. And it's filling our capacity bucket. So we're not able to do those other things that are actually going to help us move forward in feeling mentally, emotionally, spiritually, and physically well. And I think that that's what's taken out of here is the balance that's needed during this time mentally.
One of the things that we hope the guidelines will do is eliminate BMI and really de-emphasize numbers, scale-based numbers. So I find it really not unpredictable, but alarming. And basically, I would say we're completely off track, which would be that because as a psychologist, I would say if you can explain or understand behavior, you don't really have a problem. You have choices. So let's say people have actually gained numbers on the scale during COVID. Well, if they've lost their coping resources, if they've lost access to care, and they've turned to food in a way that maybe comforts them when they had other coping strategies, that's normal. You got to cope, you got to survive. That's a basic instinct, and you will do what you have to do. So we shouldn't be shaming people for the numbers going up if they say, okay, during this period of time, right? We know that if you reduce your coping strategies and if you actually change your eating habits, so I don't even know that it will be a problem. I mean, maybe it's simply like, okay, this is what we describe. And then the question becomes, are there any health impacts? Not any numbers impacts. You know, obesity is really about function, health, and quality of life. It's not about the numbers on the scale. And so I think it's really interesting that we, again, get so preoccupied with those numbers, because remember, right, all we can do is cope. All we can do is the best we can. And weight is not a behavior. End of story.
Absolutely, Michael. I just want to add to that, like, yeah, so weight's not a behavior. It should not be a target for behavior modification. And I think actually the memes about the quarantine 15, whatever, there's all sorts of ones out there, is actually weight biased manifest in the face, in the era of COVID-19. So now the only place people can get social connection is littered with bias that is acceptable bias and full of misinformation, just perhaps when that having accurate information is so important. So I think really there was an opportunity that perhaps there would be a safe place for people of all bodies which I guess is a naive thing to think, since that doesn't happen when life is normal. But now it's just weight bias manifest in the era of COVID-19, because now whether you live in a large body or not, when you go onto social media, you see it rampant with weight bias. And I think that negatively influences people across weight status in terms of their health and well-being, with this ridiculous pressure to not only not gain weight, but to somehow emerge from your house in a new physique after, like, it's just, the whole thing is, it's ridiculous.
Yeah. No, that's great. So I guess kind of going off of that, what are some actionable ways that we can support each other, I guess, that are facing the weight bias, or I guess the quarantine 15? Like, are there any online resources that could be available? Like, maybe you could, I guess, name some. I'm not sure, but.
One of the things that I encourage all my clients to do, and I do it myself, is I follow people who are weight inclusive. So my social media, I actually sometimes forget that there's people out there who engage in weight bias still, because it's so filtered. 98% of my social media is filtered to focus on people who are weight inclusive. So going to a hashtag, weight inclusive, health at every size, there's so many places that people can find the right type of connection. And again, it's being aware of resources for groups. Body Brave here in Ontario does online groups, and they are weight inclusive. There are, me and a couple of colleagues developed the Braving Body Shame Conference to bring lived experience stories all into one place for people to view and have access to. There are weight inclusive dietitians to work with and follow. There is so much out there that if we have, as professionals, if we have the knowledge of who those people are, we can send people to follow them. And that is, I start that as young as my clients at 14, is follow the right people. And so that's just I've got a whole list of suggestions that people are more than welcome to email me for.
So I love that response. I'm going to sort of just throw a little context in. So Julie says there's so much out there, and I would just add that with there's not enough out there. And so I think it's really important. We've got these little sort of pockets, which are great, but I think the message that we should all really carry is that really living with obesity, living in a larger body, this is the sort of acceptable bias. And really it's an affirmative action issue. We just have to acknowledge that it's there. We have to assume that we're operating from a position of bias, and we have to be open to then trying to do what we can to recognize and to do that. So looking for opportunities. That's why, you know, I've always really thought that the student new professional aspect of Obesity Canada has always been such an awesome sort of context. It's been really remarkable in terms of the benefit that has happened in disseminating professionals that sort of hit the ground running. Because I spend most of my time trying to train healthcare providers, and I can tell you that it's very difficult to train anybody once they've sort of developed their professional identity. Because it's like, if just search the Google search of Konrad Lorenz, spelled with a K, and he's the psychologist back in the 19th century who discovered imprinting. And you'll see these famous pictures of him walking along, and he's got the ducks following behind him. Because between hours 12 and 18 of a duck's life, they imprint on the person they're with. Usually it's mama duck. And that's why you see mama duck and all the little ones following. But if you look at Konrad Lorenz, you'll see that he's walking and all the ducks are following him. And so I always keep that image in mind, because then when you see people that have developed professional identities in which it's eat less, move more, it's all about, you can be the weight you want to be, you just have to work harder. It's really difficult to undo that. And so I think the more we can disseminate this and actually bring it to the public can be actually really important. And again, I think, I know that the German government has just acknowledged in their recent diabetes guide obesity as a chronic medical condition. So the government in Germany is now beginning to take responsibility for government dollars to address the health-related issues, and they're now sort of including this as an issue. So, you know, beginning to move forward. But anything that we can do to sort of catch some of this, and I think the hard part for us all, I find this as well, is being in a group, hearing something, and then having the courage to speak up. Because I think at some level, that's where, and Julie, that's why I say it, you know, you say there's lots, and I'm saying there's not enough, because I think somehow it's going to be, as a community, us supporting each other in that very difficult, assertive communication, like, you know, hey, that's not okay to say that, you know, that really reflects a bias, because we know that that's kind of really difficult to do. Anyway, I'll stop there.
Well, I'd just be really interested, though, to understand, like, because the word obese is so medicalized and pathologizes body, and as someone who on a BMI scale would identify myself, or a doctor would identify me as morbidly obese, I don't want to hear that. I don't want to go to a doctor and be told I'm morbidly obese and therefore, you know, have I heard of Weight Watchers? I'm fat. Of course I've heard of Weight Watchers, but my doctor has never once asked me what I ate and tells me to eat less. And this is what people in larger bodies are dealing with is, and I noticed someone over there is talking about healthism, and that's what that is, right? Is this healthism aspect. I wasn't diagnosed with my fibromyalgia because she didn't believe that I had that kind of pain naturally, and that it was because I was fat. So I think that's where it hurts, right? Is that we keep using the word obesity, and it keeps people like myself from going to a doctor and saying, I'm sick, and not hearing, well, you should lose weight. And that's the hard part with that word.
We really struggle with the terms. I think it's one of the really difficult things, and we haven't really settled on it. I think the personal side is a little bit easier, which is we just ask people how they want to talk about it, because in a group of people, even in this group here, I bet you that we would not be able to agree on a single word. On the professional side, it's challenging. There's a group in the United States that are proposing ABCD, adiposity-based chronic disease, not using the word obesity, not relating it to weight, but adiposity-based, so chronic disease. So that way you could have a high weight, but if you don't have the sort of adiposity related, then it wouldn't be a treatable condition. So it sort of tries to take it apart in terms of really getting it away. And I couldn't agree with you more, although I do support the medicalization of obesity. I do support that. Right. But I agree with everything that you've said, that somehow we've got to do this in a compassionate way that opens the door. And I know that people like Ian and other members of the Public Engagement Committee at Obesity Canada will say to you that it was the diagnosis that actually legitimized their involvement in obesity management, and they found it helpful. So somehow we've got a nuance, I think, Julie, the current narrative, which I completely agree with you, right? You know, we know that women of size are really receive terrible medical care, because everything, especially if it's sort of in the midsection, so anything to do with gut, gynae, we know that any of those symptoms are almost, you know, exclusively put off to weight, and then the latency with which a doctor will address them is really, really low. So I couldn't agree with you more, although I do think there is some value in finding a way of promoting body diversity, but also promoting health, function, quality of life.
I think that's why I like Health at Every Size, because it's talking about that social justice lens that Shelly brought up. Like, this is it, or I think maybe you did as well. And it's social justice. We need to advocate for people of size, and especially women of color living in larger bodies. They receive even worse health care than, you know, me as a white woman in a larger body. And yeah, it's important that we focus on giving everybody the same type of options, instead of you lose weight and I'm going to give you really good advice because you're in a thinner body, but you have the same issue. So it's about that care for everyone, and compassion. I love that word. Thank you for using it. I really do feel that would lead to a lot better outcomes for a lot of people.
Yeah, so I would just add to this conversation, which is really exciting, that, you know, the system is weight biased. So, you know, we as individuals, we can assess and reflect. I mean, we all have to assume from a starting place, we all have weight bias. And our clients all have weight bias, and many of our clients or patients, or whatever word you, in whatever context makes sense, will have internalized weight bias. So you go to a doctor and not receive adequate care. There are many people that will think, well, I don't deserve adequate care until my body's different. But, you know, this is internalized weight bias. So I do think language is important. I also think it's important to consider that COVID-19 is now another marginalization. So now you're going to be stigmatized because you have COVID-19 and because you live in a large body and because whatever other marginalization you have. So it's like the intersectional bias, I think, makes issues very complex, and we really need to start from the place of assuming that not only is every individual in the system influenced by the narratives and has weight bias, but the system itself, whether, I mean, I can talk about the education system being is inherently biased. So we really need to begin to look at things differently, and from that as a starting place, because for someone to say, they're not weight biased is just inaccurate. They've grown up in a system that is systemically biased.
Thank you, Shelly. That is so, so true. I teach at a local college here, and I was teaching diversity, marginalization, and oppression, and I have added in sizeism as a component, and I taught that on Wednesday, and it was amazing how many students are like, whoa, I didn't realize that there was so much involved in, because I'm teaching social service workers, how to not be weight biased in their own lives so that they're not like that with clients, especially when they're frontline workers necessarily kind of, you know, working with the homeless population. How are they going to treat different people when they come in front of them? So it's bringing that to the college has been such a passion of mine, to teach sizeism to up and coming frontline workers in social services. So important.
I'd like to pick up, I know that, you know, it was mentioned, Shelly mentioned the guidelines having a chapter on bias, which I think is actually really good. And matter of fact, I would suggest to you that the guidelines are really influenced by the whole idea of bias and destigmatizing. But I think one of the things that I would encourage people to look at in that chapter is internalized weight bias, because I think that is something that the chapter, and Shelly is one of the authors of that chapter, and they've really done a good job of doing that. Because when I talk about affirmative action, I think that's one of the really important things, is that this is a group of individuals who really are vulnerable because of this internalized weight bias. So if they actually react in a way in which they think that being poorly treated is justified, that they deserve it in some way, why would they ever act? And so there needs to be an external given permission and helping that internalized weight bias come to the surface. So I really think that that's going to be a very important construct for us all to accept. And I'd also just like to say that when we talk about bias, it's critically important that we not think about it as a 1 or a 0, a yes or a no, because what we know, and this is critically important, is that nobody is unbiased. Everybody is biased. There is too much information to pay attention to. Nobody can pay attention to it all. So selective attention is necessary. That means we all miss certain things. So we see some things and we don't see other things. Therefore, we're biased against the things we don't see. And we filter it through our own meaning system. And so, you know, Kahneman and Tversky are two psychologists in the 60s who did this research on bias and cognitive bias. And Tversky won a Nobel Prize for this work, and it was so influential in cognitive science. So I think one of the things that we can sort of think is that obesity bias isn't some sort of failing. It's not like, oh, you're biased, but I'm not, because I work in this population, therefore I can't be biased. I'm interested in this issue, therefore I can't be biased. And actually that's not true at all. Everybody is biased. So what I like about that is if we can just declare that, we can normalize bias, and we can all take responsibility for saying, right? So as a male, how do I how do I get away from that sexism bias? As somebody who's getting older, I'm starting to experience ageism bias. You know, and so I'm not suggesting that that's on a level of obesity bias. I'm just trying to make the point that I think as professionals, we need to be open to this, and compassion is going to require also us looking at ourselves and being able to ask ourselves, how am I contributing to the problems that are existing?
Yeah, so that, I mean, so that note, on that note, that includes self-compassion, because we all have weight bias. So we need to be compassionate with ourselves when we discover or uncover that we're seeing the world in a way that perpetuates that. I think, you know, maybe to bring this back to the original question, you know, calling out people on social media is a very interesting and difficult experience. And when you are a person in a large body and you're calling out weight bias, that is received very differently than a person who does not live in a large body that's calling out weight bias, because there's all these intricacies, A, to social media, B, to weight bias. But I do think that you know, one of the ways that we can try to reduce weight bias is to do our own reflection, to start from a place that we all are weight biased, to assess our own internalized weight bias, to consider what language we think we feel most comfortable with, and for sure to avoid non-person first language at minimum, and then to decide what hill you want to die on, because it can be pretty personally destructive to to call certain things out on social media. But everyone can have their passion, everyone can have the thing that they feel is something that they need to advocate or call out. There are repercussions, so you have to be prepared for those personally. But you know, normalizing quarantine 15 is a real problem that needs to be called out. So that's the hill I'll die on. But that, you know, that's a decision I make.
Yes. I'd love to just take a moment to share my screen for something that I share in a lot of webinars that I do. So if that's okay, I'm going to attempt this. Oh, look, it worked. So this is something I put together for the Dietitians of Canada talk that I did on internalized weight stigma, where I share my story alongside a dietitian who shares how it works, going back and forth. And I think this is a very simplistic list. This is not an all-inclusive list, but I did just see someone ask in the chat how healthcare professionals in larger bodies deal with their own internalized weight stigma when they're working with clients. And this is how it is we have to, just like Shelly said, dig deep, and Michael was even saying, dig deep into our own internalized stigma or bias. And so these are the questions that I have people ask themselves. This will be recorded, so you'll be able to go back, or you're more than welcome to email me for it. But these are some things to start asking yourself. I'm going to stop sharing because you don't need to necessarily read it all right this second. But one of the things that I'd like to add to that is the next question is, how would you feel if you gained 10, 15, 50, 100 pounds, right? So you might be able to be like, yeah, no, I'm good. But like Michael says, we all have that little bit of bias. How do you feel if you gain that weight, right? So does that change your weight bias then when you put it that way? And that's what we're talking about, is kind of calling out those colleagues and saying, you know, the fact that your social media is covered with green smoothies, you running, and no issues in life really doesn't perpetuate, because you know it's all fake, right? It doesn't perpetuate this life that we really are existing in. And so calling out, or I prefer calling in colleagues and saying, you know, do you know what you're actually doing harm with here? So calling in to sort of just be like, let's have a conversation. And I will die on that hill with you, Shelly. So I'm there with you.
Thank you for your great insight. I think it would be a good time to kind of pause, and if any of the attendees have questions, they can either unmute themselves and ask the questions verbally, or they can just write it on the chat. We'll just give it a minute if anyone has any questions. If not, we'll just carry on with the rest of the discussion. Checking the chat at the same time as well.
I've been trying to answer some of the chats as we go along.
Yeah, you've been moderating pretty much the chat.
Sorry.
No, it's okay.
Okay, so I don't see any questions coming up. So we're just gonna carry on with the rest of the,
Sorry, I have a question actually.
Oh, okay, yeah, go ahead.
Sorry, I just realized my video is covered up. My name is Kristen Hippel. I'm a dietitian in a diabetes clinic in a small rural community. And I actually have an intern right now doing a bit of alert review for me, but the part that I struggle with is the Canadian diabetes guidelines, and same with the weight diabetes obesity guidelines. Like you were saying, there's a lot of focus on numbers, and there's less focus on behavior. And I just wonder, like, how, if we're supposed to be practicing with evidence-based guidelines, I guess I struggle with, like, I want to be more inclusive, but I also want to make sure I'm following, like, evidence-based as a dietitian. So it's like, that's where I'm trying to shift my practice, and kind of what Dr. Vallis was saying about shifting my identity as a practitioner.
Maybe I can respond to that. I think that's a great question. We struggled so much with that, Kristen, on the executive committee of the guidelines in terms of the revisions, right? Because we were charged with writing a guideline that would be acceptable, you know, kind of at a professional level amongst other guidelines, which of course would put you in the starting position that, you know, you can only make a recommendation if there's evidence there, and the quality of the evidence determines the strength of the recommendation. So only the strong recommendations would be the ones that have meta-analysis and systematic reviews, which require funding mechanisms that allow these large studies to be done, which then, you know, sort of doesn't fund other types. So all of a sudden you could see the bias of the research. And it became a real problem for us, both in terms of what is evidence, particularly around more qualitative related experiences, and how do we navigate that. And I can tell you that behind the scenes, we clashed for quite a few times between this whole issue. You know, it doesn't meet this criteria of evidence, and where we finally kind of settled on was that, you know, the guidelines that are going to come out will acknowledge that they're too weight-centric by the evidence, but that one of the main principles of the guidelines is to go beyond the weight and get to obesity is not about the numbers on the scale, it's about health, function, and quality of life. We also addressed the issue that it's kind of seen as a little bit of a, and this may sound a bit sort of, I don't know, extreme or naive to you, but we started out saying that it had to, the guidelines need to have sort of like an ethics and a moral to them, in the sense that they're there to promote compassion, they're there to promote understanding, and they're really there to empower people to take action and to improve their lives. So we're hoping that those principles will come through, and then allow people like yourself to reference them more as a guidance document, than as sort of the evidence says that this is what you would need to do. Because the other thing is that the uptake of guidelines is about 6%. So about 6% of healthcare professionals actually are actually influenced by guidelines, and 94% of healthcare professionals use them to hold open the door or to elevate their computer monitor so that they can take a good Zoom picture. And so what we're hoping is that, again, we'll have that's why we're only publishing the executive summary. So you'll only see a short publication in the Canadian Medical Association Journal that'll come out on August 4th with 80 recommendations and about 6 pages of narrative. And that's it. That's the only thing that will appear kind of in paper. The guideline chapters will all be online, immediately accessible and downloadable. And then we begin the knowledge translation piece, which we think is really where the guidelines will be. So something like the pharmacotherapy chapter will be updated every single year. because there's a lot of research happening in pharmacotherapies now. And so the committee will continue to develop that. The behavioral chapter, we're going to focus in on knowledge translation tools. So what could we give to you, Kristen, that one might say, okay, how do you actually take a motivational interviewing approach and use the 5 A's to getting started on a journey, something like that. So I completely acknowledge what you're saying, and I think that it's actually kind of really important that we need to get it, and that the sort of professional care needs to primarily be understanding and compassionate care, which, you know, is really about understanding where people are coming from and what's important to them and how we get them to another place.
Yeah, and just to add to that, I would say if I could move your question into the realm of research, you know, Michael has a much more broad view of as on the executive of what happened with the guidelines. I'm involved in 2 chapters, the behavioral chapter and the weight bias chapter. I can say as a person who studies weight bias and is passionate about changing the system that perpetuates it, that these guidelines compared to the 2006 guidelines are infinitely more compassionate, more client-centered, more less weight biased, even in how the other chapters are presented. So I'm excited about those coming out. But if I move your question into a research realm, I would say, do we as researchers need to continue to use weight and BMI as an outcome measure or as a proxy for health? I would argue that there are other measures, and maybe this also is clinical. Maybe we don't need to be measuring weight as part of our health measures. There's lipids, there's blood pressure, there's resting heart rate, and I'm making it up because I'm not a medical person, but there are actual numbers that mean something. And I think weight doesn't really mean anything in terms of an outcome measure for what works in research, or frankly, for what's working in terms of helping our clients move towards health. So this might be a controversial thing, but I actually think that as researchers, for sure as researchers, I mean, we shouldn't be measuring weight.
Yeah.
I would just echo that. I think that's a really, really powerful statement. And I think that's something that really should be advanced upon. Weight is not a behavior, and all weight really is gravity. And so that's what you know, the gravitational force that's applied here.
And we really need to become less interested in our relationship with gravity. Why does that matter? It doesn't matter.
That's right, exactly. Exactly. I'm not so sure how much gravity shows up in our lives on a day-to-day basis in our conversations. Rachel had a comment, suggesting that we redefine successful measures. So I think that she's right on when she suggests, what are the measures that people are actually, what are the behaviors you can control? How does that improve your health, your function, your quality of life? And so I always like to say, and I try to tell, my students, measure what you treat. If you do an educational intervention, you should be measuring knowledge. If you do a behavioral intervention, you measure behavior. If you do a biomedical intervention, you measure biology. Why would you expect an educational intervention to change behavior? Why would you expect a behavioral intervention to change biology? And so I think we need to really up our game quite a lot in terms of understanding what it is that we're measuring, and also understand that these the goals we're trying to achieve are not cure based. I mean, they are behaviors that will need to be encouraged for your entire life. So it's really very much around not achieving a goal. And that's why I so much appreciate our shift in from a cognitive behavioral perspective, away from, goals towards values, and the addition of a values-oriented approach to any chronic disease management is really important, because, when does an honest person not aspire to be honest? So when is it okay for an honest person to start cheating? I mean, it would never be, because, honesty isn't a behavior. Honesty is a value. And so it organizes all of your behaviors, and you would continue to try to get closer to the value of honesty if that's what's important to you. And if you went further away from the value of honesty, that would cause you distress and you would want to move back. So we don't have to talk about, you got to motivate people. No, you have to understand people's values, and then that will line up what they need to do, and then the measurement pieces. So, you presented it as if it was controversial, Shelly, and I think it will be in some context. I find it interesting when I work in the bariatric surgery dimension and you start talking to the surgeons. And because the surgery is such a powerful impact on body weight, at least for the 5 years, it becomes challenging. But I think we need to promote what you're saying, so that the research also maps the lived experience. And I find that's what's really challenging, is that when you're treating or you're trying to support somebody, then the outcome measures in the literature don't match what the individual's experience is. It's a huge gap.
Michael, my goal in life then is I can now say it differently now that I've heard you say that, is that I think that we need to change what society values. So, the systemic problem then is that there's so much value placed on weight in the common discourses and the common narratives. I think, we can work on that and on an individual level and really work with someone, about how their life reflects what they value. In some ways, weight bias reflects what our society is valuing. I think that's what we need to change.
So I can't tell you how much of my time I spend on that issue, trying to really, and we want this talk to also have about mental health, and I would just want to sort of make a statement that the bias against obesity and all that we're talking about it just devastates mental health. And so if you can support someone and they begin to start to empower themselves and they claim their dignity, then I got to tell you, you end up spending a lot of time then trying to protect that when the individual leaves your office, leaves the intervention. They kind of go into a world that sort of just, really sort of undoes a lot of that. And so, I think shifting that narrative, and I think that's really where the patient, a committee for PEC for Obesity Canada, I think, I'm really glad that Obesity Canada has taken the position of really promoting that role, because, that they have the voice of lived experiences, which is really so important. And now most of the conferences that we go to in Obesity Canada, this is a principle behind the summit, which is every academic session has to have a patient voice in the session. So in Obesity Canada, you will never go to a session that doesn't have a plenary session that doesn't have the lived experience involved in the presentation. And that's a principle, and it's beginning to be kind of continued. I'm doing something for the European Congress on Obesity in September virtually. And again, we're having a patient dialogue to open up the session. So I think it's important that we sort of understand how much shifting the narrative can potentially empower people.
So,
right. Sorry.
It's okay. So just as someone who actually is the patient and lived experience and a counselor and is empowered, the most disempowering thing is to be treated by a medical professional who is so excited about a 2% body drop in weight. I went to an endocrinologist, and that was his excitement. And I said, well, one time I came to you on my period and one time I came not on my period. So my weight is completely irrelevant to this conversation. He didn't like that. But it's true, right? Had I not been at the position I'm in as an empowered person working in this field, that could have devastated somebody, being like, oh my God, like you've lost 2% of your body weight. This is so great. I'm like, it's just water weight. I don't know what it is, but it's not what you think it is. My blood pressure is on point and this is doing well. And, it's just so devastating as a patient to have the narrative. And so I'm really glad that this is all coming out. I don't know about the guidelines. It is what they're taught. It is now trying to change that narrative and not use the word obese. And I did notice somebody was asking about what I use. I use larger body. I use fat for myself. That's how I describe myself as a descriptor. It's a trigger word for a lot of people because it has been a stigmatized word. Higher weight body, larger body. But I ask clients, what are you comfortable with? Because I think that that's important, is what is your client actually comfortable with hearing you use? And I also think that it is never okay to gather information on weight. Replying to another person here, with a restrictive eating disorder, I think that that might actually be more devastating to some clients that I work with, for sure, with different eating disorders. So I disagree with gathering weight ever. I think Shelly's right. We do not need to measure weight. We need to measure behaviors if that's what our client wants. It's so different that way.
Thank you so much for that. Thank you for that insightful question. We do have a question. Oh yeah, go ahead. Sorry.
Well, just to pick up on Shelly's comment about, you know, the excitement with the 2%. I think it's a really useful comment to hear, because I think that will be one of the potential downfalls. So as we try to talk about what are some, you know, kind of well, how much weight change will lead to, you know, improvements in health and function and potential quality of life. And we talk about 5, 10, 15% and all that that can do from a biomedical point of view. And I think all that, so I would anticipate that we might begin to start to see more of that. That is the idea of just simplifying it and just turning it into just another number, which does the same kind of problem that we had with the weight on the scale. And so I think what we all have to really be careful for is that, you know, we work in a system that is reductionistic and deterministic. In other words, the medical system is based on a scientific model. It was called Newtonian. It was Sir Isaac Newton's view that the body was like a clock. We call it Newtonian clockwork model, which is that if there's something wrong, you can take it apart, find the offending piece, replace it, put it back together, and everything will work perfectly. And this is the basis of this sort of scientific method, which means that you can achieve two things. One is, what is the diagnosis, reductionism, and determinism, what is the mechanism of action? And then what we have to embrace is that behavior and social context is not a simple system. It's a complex or a chaotic system. And so that we need to make sure that as we shift and bring this narrative around, that we understand the complexity. And so the question would be, if your weight has changed and let's say a physician is tracking it, then the question is why? How did it change? And this is what one of the things you want to understand is that if a person makes a change, has a different outcome, how did they achieve that outcome, right? By the way, cancer is a great way of losing weight, but no one ever talks about, wow, wouldn't that be amazing? And I know that's an offensive thing to say, and I acknowledge that. But remember, if it becomes just the weight is the only important thing, then hang on, no. We have to start understanding what's underlying that, because that's what's going to be really important, is to find out, what underlies those behaviors. And I think we'll get to a point where it doesn't really matter if we're measuring function, if we're measuring health, and if we're measuring quality of life. And I think, body diversity is kind of so important. And the evidence suggests that in terms of body morphotypes, that the genetic accountability for your body morphic presentation is about 80%. So your body's shape and size is basically, about 80% genetic. So why would we enter into some kind of discussion that you can be whatever shape you want to be? And, sometimes you see these kind of body, do they call them contortion? I don't know. You can shave a little off here and a little off here, and you can turn a pear into an hourglass, or you can turn an apple into an inverted pyramid shape, which is really, really bad, I think.
Yeah,
sorry. Go ahead.
Another example that is, I think, offensive, but also very telling, is that there's been some interaction on social media about wanting to catch just a little bit of COVID-19 because it also is an excellent way to lose weight. So the horrors, to build on Michael's example, I also acknowledge that that's horrible, but it really speaks to the value that our narrative puts on our relationship with gravity. I mean, that's a horrific thing to say. Let's just catch a little bit. It's like, in the 80s where medical doctors used to say, well, if people catch a little bit of anorexia, there's way more obesity, so that's okay. It's kind of the same message that just, changes over the era, I think, but what it speaks to is our obsession with a number that is meaningless.
I spent way too many years wanting to catch a little bit of an eating disorder just to be normal. And I think that that is, when you were talking about catching a little COVID, I'm like, oh, say it, the eating disorder thing, because this is what people come into my office saying, like, I just want to, I just want to catch a little, I just want to be a little bit, you know, and it's like, but what do you really want? And it comes down to love, respect, kindness, compassion. We want, as human, we want connection, and because of the stigma, we don't have what we need, and therefore we go into this other world of wanting to shift our body size. And you're right, Michael, I look so much like my mother in my body size and shape after having my daughter. Like, I didn't before, and I had my daughter. I'm like, oh, so that's how my mom looks like this, is because she had me. Like, it just made sense. And she looks like me, and her body type is like me, and she's going to be 16, and that is a struggle for her right now. So watching her struggle with looking like me when I struggled with looking like it's this genetic code. And
so important.
Yeah, it's so important to validate that.
And, you know, this is where I think, and I'm really happy to see that. I would say to you that the new guidelines, you should see a lot of psychology in the guidelines, which I feel really happy about. And I think what you're saying is so important, right? We have to help people, you know, really promote self-esteem, right? I mean, you can't, how long have we had the phrase, you can't fool Mother Nature? And I think it's actually really important. I have a story. This is not my story. It's a woman from Ireland. She lives in Dublin. Her name is Susie Burney. We're doing the interview together for the European Congress on Obesity, and she sent me a narrative that she sort of had presented at another conference. And one of the things that she talked about that I thought was so important is when she told the story when she finally got the courage to go to an Eagles concert, and then she kind of realized at the concert that, you know, she wouldn't have, and what she said in her narrative was that she wouldn't have enjoyed the concert any more if she was, you know, 5 stone less, right? That her enjoyment of life was unrelated to her weight, right? Life is to be lived, life is to be engaged with. And all too often she tells this very powerful story of how she, you know, once she lost weight, she would do this. Once she'd achieved these goals, she would do that. And it was sort of like her life was on hold because of that sort of pursuit of this body image or this pursuit of this weight status. And I think it's just so, you know, so sad really when we see that. And I think the empathy of, if we health professionals can have empathy for that, then that's where I think we can be so helpful, right? Just imagine you're talking to somebody who's beginning that kind of narrative. Well, you know what? I'm so excited to see you because I really want to lose this weight, and when I do, I'm going to do X, Y, and Z. And you know, you could just kind of say, oh, that is, and what I do when I see that, I say, oh my goodness, that is so sad. I'm so sorry you said that. And I say something that I hope is a little bit challenging in a gentle way. Because what I'm hoping is that the person is going to say, what do you mean it's sad? Why would you say that? I've just told you my hope is to achieve X once I lose this weight. And why would you be sad for me because of that? It's like, because it has nothing to do with your weight. Why couldn't we focus on that goal right now to try to help really with that sort of empowerment piece? Because you know what? You know, have a look in the mirror and have a really good look in the mirror, because what you see looking back at you is going to be there your whole life.
Mine was a leather jacket. I wanted to lose the weight to buy a leather jacket, and I didn't tell anybody that. And when I graduated from my counseling program, my mom bought me a gift card to the leather place in town, and I bought myself a red leather jacket. And I hadn't changed sizes, and it really did start to impact how I viewed my life. Is I don't have to wait, and if I kept waiting, I never would have had that gorgeous red leather jacket. And that's sad. You're right. It's devastating to hear people waiting to enjoy their life. Devastating.
So I just wanted to bring out a question and get your opinion on it. So, you know, as a student, so many of us may want to pursue a career in research or already, doing some research. And obviously, you know, measuring weight is one of the easiest, quantifiable things that we can do. And, in opposed to measuring weight and per se, let's say, focusing on behavior, what are some of the ways to measure behavior in a sense that can be presented, as a, research data, or make it more quantifiable? I'm
not a researcher,
right.
But I think, first of all, remembering that the N in research, from my limited research knowledge, is a person. And I measure things like their consistent self-care, their ability to intuitively listen to their body. Like when we're born, we can listen to our bodies and we lose that. So how are they listening to their bodies? And then are they engaging in joyful movement or punishing movement, right? Are they enjoying life? So I don't know how you do that as a researcher, but let me tell you, it would make so many people feel included in research if it was about those kind of measures. I just, that's what I feel.
Thanks. I'll make a comment about that because I do research and I'm a behavioral person. I actually have, so I don't believe in the truth. I think that, you know, everybody's truth is different and unique and that it's complex. So I have no problem with subjective data. If you want to lie, go ahead and lie. And, you know, but know that, you know, self-report is underestimated as in terms of its value. It doesn't have, let's say, as much kind of validity between people, but it has a lot of reliability. So if people measure change, then it's a lot easier to do that. There are some really interesting measures that we can do now. There's something called ecological momentary assessment. Just imagine everybody on the call that you got a text right now that said to you, can you please report what did you eat since you woke up this morning? And do you know that I mean, somebody, you know, shout out if you could not answer that question. So it's now, well, depending on where you are in the country, it's 1:11 p.m. in Halifax. And so I can tell you what I ate today. You know, others of you could probably tell what you ate today. So that's okay. So you can be really, really accurate. Technology can measure a lot of behaviors. The other comment about this is that if you talk about how does medicine work, and so much about medicine is judgment. So much of medicine is like, how have you been feeling, Julie, since the last time I saw you? What's your range of motion been like? And those are how the doctor will treat you. So the doctor uses behavioral measures as well. So in a way, I think there's also a little bit of, and it stems from the science model, but a little bit of a bias against the behavioral perspective. But I have no problem sort of accepting. There's in psychology and psychotherapy, we do the following type of a measure, which is called goal attainment scaling. In other words, I don't use the Beck Depression Inventory, this measure, that measure. I say, okay, Julie, what are the goals that you have in your therapy? Okay, now let's reflect. So your first goal, how much, to what extent have you attained this goal? Second goal. And so, and you don't even know what the goal is. You just know that you're assessing what the individual's personal goals are. And then they're reflecting on the degree to which they're making change. Actually, something that is both reliable and predictive. Would it surprise you to know that, you know, the people that are more likely to attain their goal actually end up being able to function better and achieving these other goals? So I'm totally okay with this kind of the subjective piece, because I think we overestimate the objective piece. And the only exception to that is I love brain scans, and I just love how brain scans are being connected to behavior and how we're actually starting to look at things like, okay, how strong is your executive functioning? And based on how strong your executive functioning is, that will predict how much restraint you can apply to the temptations of the day. And if you have, let's say, moderate or lower levels of executive functioning, we shouldn't be asking you to do things that require a higher level of executive function, because you're going to feel bad about yourself, right? And so we're beginning to learn how some of that biology can actually connect to behavior. And it's very, very fascinating, because it actually, I think, can be used positively.
And I would just add to the conversation about that to say, you know, I don't know, there's been a historical obsession with measuring weight as an outcome and as a proxy for health. And I would argue, just because other researchers are using weight as a measure doesn't mean that we all have to be unethical and do it. Because if there was any other measure that meant nothing but hurt hurt people psychologically, we would stop using it. I don't know. I just don't understand. You can measure BMI pre and post research, but what does that tell you? It doesn't mean anything. So it's similar to the conversation that we've had about language. So if I choose as a researcher not to measure BMI, I know there's certain journals that I'll never be accepted into. I just won't be, because that will be considered somehow a fatal flaw. I've landed on using the language of, person in a large body to describe what other people might call someone who's been classified as obese, but when I use that language, I'm consistently challenged with some journals with pushback about using that. And so, at the same time as you're trying to disrupt the system, you're kind of trying to work with it from inside, because I want the journals that insist that I measure BMI pre and post intervention to be challenged a little bit about that as something that measures anything. So I would say to that, just because other researchers are unethical doesn't mean you have to be. Let's change how we're doing that.
Thank you so much
everyone,
for the great insight. Go ahead.
Yeah.
Go ahead.
Yeah, I'm Stephen, GP from Malaysia. So regarding not using weight as a measure of BMI as a measure, you guys in Canada are really far ahead. But just to heads up to you all that I think we are fighting against a billion-dollar industry whereby they use weight to easily judge and to measure someone's disease, which is obesity. So we need to move slow and not. And if we too aggressive, then it will become a counter effect. So we need to have a very well-planned strategy, and education definitely is one of the main strategy. So with the clinical practice guideline coming out, I hope that more and more people are shifting away from this weight and move towards behavior outcome. So I was also keep on tracking the weight, but now I learned that actually we should track the behavior, because that will be a lifelong change for our patients. So these are some of my comments. Thank you.
I think that's a great comment, Stephen. I couldn't agree more. I very much appreciate what Shelly says. I will just say that for my interactions, though, I take a little more collaborative approach in the sense of trying to represent, because there's an in chronic disease outcomes, and that is patient-reported outcomes. So this and shared decision making. So for instance, all the major funders, whether they be kind of industry funded research or academic funded research, insists on patient reported outcomes. And I think there's a tremendous ability to leverage that, so that they're not just throw in the SF-36 and tick that little box, but to actually to draw out those patient reported outcomes. The FDA in the United States is primarily because of biologics and now biosimilars. So for those of you who don't know, a biologic kind of works really on your sort of immune system directly, and it's kind of working really, really internally on your. So have powerful drugs, and they're being primarily used around inflammatory conditions, which are kind of really be huge. But then there are these drugs called biosimilars, and what that means is that if you make a drug that's similar, you don't have to have it vetted through FDA. If I approve drug A and I create a biosimilar, I don't have to submit drug B. Terrifies me to think that this is actually the case, but nonetheless, this is the issue. But one of the things that the FDA has sort of been doing is going towards what's called shared decision making, to the point where they're actually going to say that a physician cannot sort of competently prescribe a medication unless they have documented explicit shared decision making. So I see my hope, and where I spend a lot of my energy, is sort of in this medical space, trying to, through patient-reported outcomes, shared decision making, really try to focus on communication, empowerment, and then the measurements that are more psychological and behavioral, hoping that then the journals, Shelly, will will, you know, not exclude a paper that, you know, would have sort of a broader framework. So, but I really appreciate your comment, Stephen, and I would say that we look a little more impressive than we are as Canadians in the obesity field. So thank you for your compliment, but I don't know that we really justify it because we talk the talk more than we walk the walk. And I'm just speaking about the country kind of as a whole. I think we have pockets, but I think we also have a lot of room to move.
Yeah, and I do think, Stephen, that you're quite insightful in thinking about, like, you know, there's multiple ways to disrupt the system. So we need to think about how to do that, right? So 10 years ago, I did measure weight, BMI, pre and post. I've only recently come into my own, I would say, to say that I feel brave enough to not do that in my research on ethical grounds, well, and I would also argue on scientific grounds, but I've grown in how I want to disrupt the system over time as well. And I think if, you know, one way to do it is just go in and blow the whole thing up. But I'm not sure that that is always the best strategy. So I do think that, you know, sometimes you have to push the rock up the hill kind of slowly, and, you know, maybe other times. So I think it's quite insightful of you to say, like, you know, here maybe it's a bit slower, we can't quite, you know, and also that is something that I would choose my audience to share about, right? So I think we're moving really slowly in some places and perhaps blowing up the system in other places. And I think, you know, you do have to think about your context and your audience in terms of trying to shift the bias in the system.
I would just throw in, I'm mindful that this is a student, new professional, organized discussion. And so I would encourage all of the young professionals in the audience to try to think about, where do you fit in this discussion? So you see Julie, you see Shelly, you see myself, we've heard from Stephen, we've heard from a few, Kristen has talked. And so where do you fit? Are you going to be the ones that are kind of packing the explosives? Because we need people like that, right? That's why, you know, when we were writing the behavioral chapter, we asked Shelly to help us with the behavioral chapter because we knew that she would hold our feet to the fire. And that she would be the one that would make sure that we didn't drift away, because we can't be trusted not for the world not to make sense to us, right? So my world makes sense to me, so I guess it's going to make sense to you. You need different sort of people. As I've described, see myself a little bit more kind of inside the camp, trying to kind of mediate, and so if you could all think about where would you fit. And I think the key here is that, you know, we need to really be like a patchwork quilt. We need to be pulled together by our diversity, and that all the voices need to be sort of representative and involved. And I can say that I've had a very long career, and I've been incredibly grateful to be a health psychologist. And the reason for that is because I've always worked inside the medical system. So I've always worked alongside of dietitians and nurses and physios and pharmacists and social workers and physicians. And for me, I think that's been one of the most positive aspects, is that, is that everybody has a voice, and when you pull those together. So we're talking about some really important issues here. And I think that what's your contribution to moving this forward? Because there are going to be times when we need to blow a bridge so that we can stop the flow of traffic from this direction. And other times when we're going to need to sit down at the negotiating table like the EU did just last week and sort of hammer out a post-COVID financial bailout of the European Union, which they were successful at doing. So I think that's something that we need to be mindful of. And I always appreciate, you know, the tension that happens when I talk to people like Julie and Shelly, because, you know, we can kind of see, you know what, I use the word obesity. Oh, Julie's offended by that word. Okay, well, that's actually really helpful, right? Because, you know, and I kind of said, I kind of think that it's kind of I'm behind sort of the medicalization within limits, and other people, I don't want to medicalize it. And I think we need all these voices to be sort of loud and clear, so that we can sort of find a path that sort of does really advance, because this is about promoting worth and dignity, health and well-being in individuals. And I think if we And that's why what I like about kind of clinical medicine is that as much as we can criticize healthcare professionals, almost all of the time they're actually doing their best to help their patient. And they may not be knowing what they're doing, so they may actually go into something that Shelly would say that they're maybe crossing the ethical boundary. I think that's awesome to think about that. How might we be able to pull them from going over the precipice? Because if they go over the precipice, guess what? They actually think they're helping the patient. So this is where those alternative opinions can be really helpful.
I would just love to just interject one last thing. And when you're saying for them to find who they are, and as a student, listen to the lived experiences. This is your best education, is the lived experience of the people who you're either researching or you're working with. I could not be where I am in my education mind without my practice of working with clients, of running groups, of running a conference about this. I would not be where I am without the people who have come alongside me as a client and as a colleague in weight inclusive care. So listen to the voices, and that is so important, so important.
Just looking at time, I wanted to ask just another question, just because this is a pretty interesting question, and it just obviously, of course, relates to COVID-19. So how is obesity care delivered virtually? And also, what can we do to ensure virtual delivery of care, and that it's also free from bias and stigma?
Could I start that? Because I have a strong opinion about that.
Yeah, of course.
And that is that there is no barrier to virtual care other than what's in the clinician's mind. And we need to just get over ourselves. If the patient, if the individual is willing to talk to us, then I think we just do it. And I'll tell you, I believe virtual care will improve chronic disease self-management. And I'll just tell you why, if you will indulge me for 1 second. Imagine what it's like for a patient to get care. They go to an appointment that's given to them primarily at the convenience of the clinician. They have to interrupt their day. They get in their car, they drive to the hospital, they pay for parking, they surrender their health card and become a number, not a person. They go into a waiting room and they wait until the person is ready to see. They walk into an office with somebody else's name on the door, someone else's children's pictures on the wall, and they receive care. And then we wonder why, when they go home, do they not incorporate the messages? In virtual care, we're going into the person's home. So no offense to the dietitians, I love plastic food. I understand its value in educating in diabetes management around plastic food. I do agree with it. I have no problem with
plastic food.
But imagine virtually when you can say to your patient, show me your fridge. Open your cupboard door. Where do you have your meals? What's it look like when you prepare your food? I would just want to make that comment that I think the virtual care the barriers are ours, not the patients. And we know the genie's out of the bottle because patients do not want to go back to always seeing you. So Julie, I wouldn't be surprised if your patients say to you, you know what, could I come in maybe every second time? And maybe what we could do is between every second appointment, maybe I could see you virtually, and it wouldn't, that way I wouldn't have to, I could put my kids on, I could get my kids doing their homework, and we could go into the next room. Anyway, I'm sorry, that's a strong opinion.
No, I also think when the snow falls here, it'll be great to have more people understanding that virtual care is care. What I had for this question is, how can healthcare, because again, I don't use that word, be delivered virtually, is we have to be aware of the weight inclusive resources for groups, counselors, dietitians, physicians, whomever, and what books to suggest. What I love about working virtually is my bookshelf is all behind me and in front of me, and I'm like, oh, just wait, I've got a good resource for that, and I can just run over and grab like The Body Is Not an Apology or Body Respect and say, this is what we need to look at. And I love it because if I forget about something, I have 10 minutes to get up my stairs instead of driving over to my office. But I think the delivery of care, we as clinicians need to know what's available. And yes, Michael, of course, it's not enough, but there is a lot out there that isn't being utilized. So know what is there. Know what your clients can benefit from. If you don't know, go find out. Google is great. And if you don't want to Google, contact somebody who you've seen speak who knows about this stuff. We're out there.
Yeah, I would just throw in the idea that I think we can all be very thankful to Arya Sharma, who's really done I think a really good job of promoting Obesity Canada as a resource and as a place to receive some of that information. So I couldn't agree more. I think we really do need to be aware of the resources that are there and encouraging the access of that material, because it's just so important.
Okay, and I think we are right on time at 9:29. Just wanted to do some summary and the closing remarks. Well, first of all, thank you, Julie, Michael, and Shelly, for your wonderful insights. We definitely enjoyed listening to your thoughts and experience on obesity management and weight bias. And for the audience, thanks for joining us as well. This was our very first webinar at the student and new professional level, and it was done by a national collaboration. We had people from Vancouver, myself, and we had like people all the way on the east and from Alberta as well. So we had everyone involved in this. It was a big project, so thanks for joining us. And I think we will put the recording up as well. So we will send you the link to the recording if you would like to watch that again. And if you have not joined Obesity Canada, please do so. There are great resources available on their website, and you're also able to check out if there is a local chapter available in your area, whether it's like a local Obesity Canada chapter or local Obesity Canada student and your professional chapter. And if so, feel free to join, and so we can grow the support and grow the network bigger. We will be hanging around. I think the panelists will probably just head out, but we as the moderators and the rest of the national executive team will hang around. So if you would like to remain in the meeting and ask questions and have discussion, we'll be more than happy to answer those questions. Thank you.
Thank you. Thanks for inviting me. Great to chat.
Thanks, that was fun. Thanks.
Thank
Okay.
you so
Thanks,
much.
Julie. Thanks, Shelly.
Bye, nice to meet you guys.
Thank you, everyone.
Thank you.